In rapidly evolving world of medical research, staying current, well, it can often feel like trying to drink from a fire hose, right?
Absolutely. Information overload is a real challenge.
So how do we cut through all that noise, understand the truly transformative breakthroughs, and really get to what matters?
That's the key question.
And that's precisely what we aim to do here on the deep dive, to distill those critical insights and hopefully arm you with some truly well-informed perspectives. Today, our deep dive takes us into a really pivotal 2024 research article. It's from the Alzheimer's Association Workgroup.
Yes, the revised criteria for diagnosis and staging of Alzheimer's disease.
Exactly. And this isn't just a minor tweak, is it? Not just a slight adjustment to the playbook we're used to.
Oh, far from it. This represents, a monumental shift. It changes how we conceptualize, diagnose, and even, discuss Alzheimer's disease.
It sounds like a foundational change, really.
It is. It rewrites some core assumptions we've held for a long time.
Okay, so our mission today is to unpack these revised criteria. We want to explore this paradigm shift from sort of symptoms first to a purely biological diagnosis.
Right. And look at the new diagnostic tools becoming available.
Yes, some incredibly accessible tools, it seems. And we'll examine how this fundamentally impacts individuals, clinical practice, and of course, the future of treatment.
And we'll definitely highlight why diagnosing AD before symptoms even appear is now actually a reality, and what profound implications that holds.
So prepare to discover some perhaps surprising facts and gain, hopefully, a shortcut to being truly well-informed on this critical, fast-moving topic.
Let's dive in.
Let's start with what I think is the biggest conceptual leap here. For decades, our understanding of Alzheimer's has been so closely linked to the observable symptoms,
The memory loss, the confusion.
It's exactly, the functional decline. But this new framework, it proposes something radically different, doesn't it?
Absolutely. What's truly fascinating here is this definitive shift, defining Alzheimer's disease, AD, as a biological process.
A biological process?
Yes, specifically, they call it Alzheimer's disease neuropathologic change, or ADNPC. Think of it kind of like how we've understood diseases like cancer for a long time.
Okay.
The idea is that the presence of specific biological changes in the brain, that is the disease now, even long before any clinical symptoms might show up.
So let me see if I've got this right. The disease literally begins with these biological changes in the brain. And the symptoms we see later, they're a result of that process.
Precise.
Rather than being the definition of the disease itself, it's sort of flipping the cause and effect we used to assume.
You've got it. The document is quite clear. The progression of this neuropathologic burden that leads to the later appearance and progression of clinical symptoms, which means AD can exist for years, maybe even decades, while an individual is completely asymptomatic. They feel fine.
Right.
But the detection of that ADNPC through biomarkers is now basically equivalent to diagnosing the disease itself.
This raises a really powerful question, then, for anyone trying to grasp this. For you, the listener. If AD is a biological process that can start long before any outward signs, how does that fundamentally change our perception of when the disease truly begins for someone?
It really challenges our traditional view.
Yeah, and the paper uses that stark illustration with Down syndrome. Virtually all individuals having sufficient ADNPC by their mid-40s, leading to a 95% lifetime risk of dementia.
It's a striking example. It suggests this ADNPC isn't just some benign finding, even if other health issues might intervene before dementia develops.
So what does it mean for individuals, for society, to potentially know someone has a biological disease process unfolding maybe decades before symptoms?
Well, it forces us to confront what disease truly means, doesn't it?
Yeah.
Shifting from something you see to an underlying biological reality.
Yeah.
And the implications for, say, patient counseling, long-term planning, even personal identity,
Yep.
they become incredibly complex, important conversations we need to start having.
That's a profound thought. Okay, so this biological definition, it hinges entirely on our ability to detect these underlying changes, these biomarkers.
Exactly.
And the paper introduces a much more refined way of categorizing them, right?
Indeed. They're now grouped into two main categories reflecting that AD neuropathologic change: Core 1 and Core 2.
Core 1 and Core 2, okay.
Core 1 biomarkers are the early changing ones. These include amyloid peaky scans,
Right.
approved CSF biomarkers, so from spinal fluid like A42/40 ratios, and crucially, they now explicitly include accurate plasma biomarkers, blood tests,
Blood tests. That sounds huge.
especially phosphorylated tau 217, p-tau 217. The document emphasizes that an abnormal core 1 result is actually sufficient to establish an AD diagnosis.
Even in someone with no symptoms?
Even in asymptomatic individuals, yes. They reflect the presence of AD NPC, more generally plaques and tangles.
Okay, that's core 1. What about core 2?
So core 2 biomarkers are the later changing markers. This includes tau PET scans and certain soluble tau fragments like MTBR tau 243 and other specific p-tau forms like p-tau 205.
So these show up later in the process?
Correct. They become abnormal later in the disease evolution and are more closely linked with the actual onset of clinical symptoms.
Ah, okay.
So when core 2 markers are abnormal, they increase confidence that AD is indeed contributing to a patient's symptoms, and they can help stage the biological severity of the disease.
This is where it gets really interesting, I think, especially for you, the learner. The rise of these accurate plasma biomarkers, blood tests. What does accurate actually mean here, and why is this potentially such a game changer?
Well, accurate in this context means achieving a minimum of 90% accuracy in detecting abnormal amyloid PET results in the specific group they're intended for.
90%, that's high.
Or demonstrating performance that's equivalent to the already approved CSF assays. The development of these highly accurate blood tests, it's projected to revolutionize clinical care.
And research, too.
By making biological diagnosis far more accessible. Think about it, much easier than needing expensive PT scans or invasive lumbar punctures for CSF.
Right, much more scalable.
Exactly. But it's important to note, not all blood tests are created equal in their diagnostic power. For instance, plasma A4240 assays. They typically have a much smaller diagnostic range, maybe a 10–15% difference between normal and abnormal.
Yep.
Compare that to CSF A4240, which has around a 50% difference, or the plasma P2217, which is also much more robust. So accuracy varies.
Still, the prospect of moving from complex, often invasive tests to potentially just a simple blood draw. That sounds profoundly exciting. What are the immediate implications for accessibility for populations maybe underserved by PT scans or specialists?
Well, it's immense. Imagine the impact on rural communities or places with limited access to specialized imaging centers.
It really lowers the barrier.
It democratizes access to early diagnosis, which is just crucial for future interventions and for research participation. It also makes screening, large populations a much more realistic possibility down the line.
Okay, so the big takeaway is an abnormal core 1 biomarker is enough for an AD diagnosis. But you mentioned nuances. The document stresses clinical judgment is still key.
Yes, this is a really important point. While core 1 biomarkers define that initial detectable stage of AD, we have to remember their limitations.
Such as?
Well, for example, biomarkers are actually less sensitive than a full neuropathologic exam, like an autopsy, for detecting very early or mild AD NPC.
Ah.
So a normal core 1 amyloid biomarker result, it doesn't automatically mean the brain is completely free of plaques. It just means the burden hasn't hit the detection threshold for that specific test.
So what happens if a patient comes in, symptoms strongly suggest AD, maybe memory problems, confusion, but their core 1 biomarker is negative? It's not automatically not AD then.
Exactly. That's precisely where clinical judgment becomes essential. The paper explicitly states, clinicians must always assess whether AD is the dominant contributor to a patient's symptoms.
Dominant contributor, because there could be other things going on.
Precisely. Especially given how common copathologies are in older adults.
Yeah.
Other brain issues happening at the same time.
Like what, for instance?
Well, say someone has symptoms of Parkinsonism, maybe visual hallucinations, alongside positive core 1 markers for AD. A clinician needs to carefully weigh the contribution of AD versus perhaps a neuronal synuclein disease like Lewy body dementia.
I see. It's complex.
And other things too. Confounding conditions like a recent head trauma or even impaired kidney function can sometimes transiently affect biomarker values. It adds layers of complexity to the interpretation.
That's fascinating. So these incredibly precise new biological tools, they actually increase the demand for skilled human interpretation rather than making the clinician somehow obsolete.
Absolutely. They don't replace clinical skill. They enhance it, or should.
The document even suggests having an indeterminate zone for biomarker values near the cutoff point, right? To prompt more thinking or testing.
Exactly, a sort of gray area. The guidance recommends biomarker testing only under the supervision of a clinician. It emphasizes that this biologically based diagnosis is meant to assist clinical evaluation, not replace it.
Right.
So for you, the listener, this means understanding that while the science is advancing incredibly fast, that human element of medicine, the thoughtful analysis by a trained clinician, remains absolutely paramount. It's about integrating these powerful tools wisely.
Okay, so once we've established the presence of AD biologically, the next critical step is understanding its trajectory. Where is it heading? How do these new criteria help us map the progression of AD?
Right. Diagnosis is one thing, staging is another.
Yeah.
The document introduces a distinct four-stage biological scheme. They use letters A, B, C, and D.
A, B, C, D. Okay.
And this scheme is based on the sort of sequential evolution observed in studies that watch people over time, mainly using amyloid and tau PET scans.
So what do the stages represent?
Stage A is the initial biological stage. You have abnormal amyloid PE, but no significant tau buildup showing on a tau PE scan yet. A plus T2O.
Got it. Amyloid first.
Then stage B is early. Abnormal amyloid PE with tau PE uptake, but it's restricted to the medial temporal areas of the brain, like the hippocampus. A plus T2MTL plus.
Still fairly localized tau.
Exactly. Stage C is intermediate. Abnormal amyloid PE with moderate tau PE uptake spreading into the neocortex. A plus T2MOD plus.
So the tau is spreading outwards.
Yes. And finally, stage D is advanced, characterized by abnormal amyloid PE and high neocortical tau PE uptake, widespread tau. A plus T2HIGH plus.
Okay. A clear biological progression. Can the blood tests or CSF tests distinguish these stages?
Ah, good question. While the fluid biomarkers blood or CSF can establish that an individual is in biological stage A or higher, they can't yet reliably or accurately discriminate between those later PD stages B, C, and D. PT is still needed for that detailed spatial staging of tau.
That makes sense. It really helps visualize the disease spreading, though, like, as you said, tracking a wildfire in the brain from a spark to a full blaze. But how does that biological staging relate back to the clinical symptoms, the things we actually observe in a person?
Right. The biology doesn't always perfectly match the clinical picture. That's where clinical staging comes in. The paper updates a familiar six-stage numeric scheme, 1 through 6, but significantly adds an entirely new stage 0.
Stage 0, what's that?
Stage 0 represents genetically determined AD. Think of conditions like Down syndrome or autosomal dominant AD, where the risk is extremely high or certain. This is for someone who is biomarker negative currently and clinically asymptomatic. But the disease risk is essentially present from birth due to genetics.
Wow, okay.
Yeah.
So disease defined purely by genetic destiny, even before biomarkers turn positive?
In a sense, yes. Then stage 1 is someone who is asymptomatic but does have positive biomarker evidence of AD. Biological disease is present, but no symptoms yet.
Okay, the preclinical stage we hear about.
Yes, exactly. Stage 2 is termed transitional decline. This means mild, detectable changes, maybe subtle objective memory issues on testing, or even just subjective cognitive decline the person notices. Maybe subtle neurobehavioral changes, but with minimal impact on their complex daily functioning.
Sort of the earliest hint of trouble?
Kind of. Then stage 3 involves clear cognitive impairment that starts to have an early functional impact, maybe on managing finances, complex tasks, that sort of thing.
Okay, what used to be called mild cognitive impairment, or MCI, due to AD.
Largely, yes. And then stages 4 through 6 represent progressively worse dementia, with increasing functional impairment ranging from mild dementia in stage 4 to severe dementia in stage 6.
What seems really insightful here is the idea of integrated staging, combining both the biological stages, AD, and these clinical stages, 0-6. Because they don't always move in lockstep, do they?
Exactly, and that's critical. This integrated approach recognizes that individual variability.
How so?
Well, you might have someone in an early biological stage, say stage B, but they might have more advanced clinical symptoms, maybe stage 4, because they also have significant vascular damage or another brain disease, those copathologies we mentioned.
Right, making their overall function worse than the AD alone would suggest.
Precisely. Or, conversely, you could have someone in an advanced biological stage, like stage D with widespread tau, but they might present with relatively milder clinical symptoms, maybe stage 3.
Why would that happen?
Often attributed to high cognitive reserve, maybe years of education, complex occupation, strong social networks, things that seem to build resilience against the pathology.
Interesting.
So this integrated staging allows for a much more personalized, accurate picture of an individual's specific situation. It moves us beyond a simple, one-size-fits-all progression model. It's really about describing that individual's journey with the disease.
This whole deep dive really underscores just how complex the brain is, and that AD often doesn't exist in isolation. What other factors are clinicians now looking at beyond amyloid and tau to get the fullest picture?
Yeah, the framework explicitly acknowledges this complexity by introducing non-core biomarker categories. They often use the acronym NIVS to talk about these.
NIVS. Okay, what do they stand for?
So the N is for neurodegeneration. These are markers like neurofilament light chain, NFL, which you can measure in blood or CSF. It indicates nerve cell damage, but isn't specific to AD. Or things like brain volume loss on an anatomic MRI, or reduced glucose metabolism on an FDG PET scan. General signs of neuronal injury.
Okay, N for neurodegeneration. What's I?
I is for inflammation. A key marker here is GFP, glial fibrillary acidic protein, which indicates activation of astrocytes, a type of glial cell involved in brain inflammation.
Inflammation playing a role. Got it. V.
V is for vascular brain injury. This usually refers to imaging findings on MRI, like evidence of small or large strokes, or those white matter hyperintensities we often see, indicating small vessel disease.
Okay, vascular contributions. And S.
S is for alpha-synucleinopathy. These are markers aimed at detecting the pathology associated with diseases like Parkinson's or dementia with Lewy bodies. The most promising here are the alpha-synuclein seed amplification assays, or ASYN-SAA.
So NIVS helps capture those common copathologies.
Exactly. And they introduce a useful concept related to this, the T2N mismatch.
T2N mismatch.
Yeah, it's where you see tau pathology on a PET scan, the T2. But there's also evidence of significant neurodegeneration, the N, that seems out of proportion to the amount of tau. The tau alone can't explain all the damage.
What does that usually point to?
It often signals the presence of another neurodegenerative disease alongside the AD tauopathy. A common one is late limbic-associated TDP-43 encephalopathy. It highlights the need to look beyond just A&T.
So it really emphasizes that the goal isn't just diagnosing AD in isolation, but understanding the whole ecosystem of an individual's brain health. Very comprehensive.
It has to be.
And speaking of the broader picture, the paper also touches on the impact of new treatments, which have obviously shifted the landscape quite a bit.
Yes, absolutely. The anti-amyloid immunotherapies, they are truly transformative in many ways.
How so?
Well, they demonstrably reduce amyloid plaques in the brain, which we can see on PE scans. They also tend to normalize downstream biomarkers like p-tau and GFP. And importantly, clinical trials have shown they can slow the rate of cognitive decline.
Which is a huge step forward.
A massive step. However, a really key insight from this paper is that even with successful plaque reduction, the underlying AD pathophysiologic process is considered still active.
Still active, even with the plaques gone.
That's the current understanding. They've even termed this phenomena treatment-related amyloid clearance, or TRC. It signifies that the amyloid has been cleared by the treatment, but the disease process itself isn't necessarily eradicated or cured in the traditional sense.
That's a really critical distinction.
Yeah.
So if these therapies reduce plaques, slow decline, but the underlying process is still active, what does that mean for how we should frame success in treatment? And what challenges does that pose for long-term care?
It definitely shifts the definition of success. It moves away from cure towards disease modification and symptom management, or slowing progression.
More like managing a chronic condition.
Exactly, like managing diabetes or heart disease. For long-term care, it implies continued monitoring, potentially ongoing or intermittent therapies, and a clear acknowledgement that this is a chronic condition we're learning to manage over the long haul.
Which puts more emphasis on integrated care, patient education.
Both. Integrated care teams become even more important, and ensuring patients and families understand the goals of treatment and the chronic nature of the condition is crucial.
Okay. So, as we start to wrap up this deep dive, looking ahead, what does this new framework really mean for the future of Alzheimer's research and clinical care? What should we all be watching for?
Well, the document itself outlines several absolutely crucial future directions. First and foremost, the urgent need for more representative cohorts in research.
Meaning more diversity.
Exactly. Moving beyond the primarily educated non-Hispanic white populations that have dominated many past studies. This is vital to ensure diagnostics and treatments are actually effective and equitable across all demographic groups. We can't assume findings from one group apply universally.
That's incredibly important. What else?
Continued standardization of assays, making sure tests are reliable and comparable across different labs and platforms. A deeper understanding of tau pathology in all its forms. And a much more prominent role for inflammatory biomarkers like GFE, understanding their role and how they change with disease and treatment.
It sounds like the goal is even greater precision.
Ultimately, yes. The long-term vision is for a truly comprehensive system to stratify risk. one that incorporates all these biomarkers, core 1, core 2, NIVS, alongside demographics, genetics, maybe even lifestyle
To
factors.
create a truly personalized approach.
Exactly. Personalized risk assessment, leading to personalized prevention strategies and tailored treatment plans. That's the future they're aiming for.
This deep dive has certainly shown us that our understanding of Alzheimer's is undergoing, well, a profound transformation. It's really shifting
It truly is.
from defining it biologically to using these potentially accessible blood tests to mapping its progression with these intricate staging systems. We're getting unprecedented clarity and precision.
It's a remarkable journey, isn't it? From just observing symptoms, often quite late in the process, to directly detecting the underlying biological changes that drive the disease much, much earlier.
And that offers real, tangible hope.
It does. Hope for earlier intervention, more targeted research, and ultimately, more personalized care. This biological shift really empowers us to potentially intervene earlier and more effectively than ever before.
So for those of us following this field, for you, the listener, we hope this deep dive has provided not just a collection of facts, but a solid framework, a way to truly understand this rapidly evolving, complex, and incredibly vital area of medicine.
Indeed. And it leaves us with some big questions to ponder, doesn't it? As these biological definitions become more refined, and as blood tests potentially become ubiquitous, how might our societal conversations around aging, memory, and cognitive health evolve?
That's a big one.
And maybe even more profoundly, what could a truly preventative era for Alzheimer's disease look like in the next decade? Moving beyond just treatment into real risk stratification and proactive intervention for potentially everyone. What would that future hold?